Good morning, everyone. On behalf of EchoSense North America, I would like to say thank you to the webinar and thank the CLDF for sponsoring this event. I'd like to introduce today's speaker, Dr. Elliot Tapper from the University of Michigan. Dr. Tapper is an associate professor of medicine in the Division of Gastroenterology. His clinical activity and research efforts focus on improving the outcomes of patients with cirrhosis, with emphasis on interventions for hepatic encephalopathy and hospital readmissions. Prior to joining the faculty at the University of Michigan, Dr. Tapper was a transplant hepatologist and chief resident at Beth Israel Deaconess at Boston. Dr. Tapper.
Well, thank you very much. It's my pleasure to be here, and I look forward to speaking with you over the next 40 minutes about a topic near and dear to my heart, reviewing the major takeaways from our recent review in the New England Journal, but taking a deeper dive into the clinical role that non-invasive tests for the presence of advanced fibrosis will play for each of us. So we're here today for a few reasons. One, I'm very thankful to the CLDF and EchoSense for supporting this webinar. Two, and most importantly, we're here to discuss this for clinicians at the front line, and I'm very happy and privileged to be joined by you. And three, we're talking about changes in clinical practice which are very important to major segments of the population who present for care in hepatology clinic. First, we are now in the process of being able to eradicate hepatitis C, and with more and more people presenting to our clinic as a function of screening the population and awareness of the efficacy of our treatments, it is incumbent upon us to perform a risk assessment and understand the underlying burden of liver disease for a couple of reasons. One, we cannot miss the presence of cirrhosis, and two, the insurers ask that we do. In order to prioritize the treatment of hepatitis C in this current regulatory environment. In many cases, some payers are still reserving treatment for patients with the most advanced burden of liver disease. And two, and more importantly, as we start to look towards the post-hepatitis C era, is the rising tide of non-alcoholic fatty liver disease. And we all know this from clinical practice, but I'll review some data briefly. One is that the prevalence of NAFLD in the United States ranges as high as 20 to 30% depending on how you count the population, and within certain subgroups, particularly those who have diabetes, those who are 60 and over. When you look at a population sample from a nationalized estimate, such as from the NHANES study, the estimates of the prevalence of NAFLD are in excess of 50%. This will be the defining liver disease of the future, and how we handle this in an efficient and cost-effective, patient-centered way will be one of the defining features of our clinical practice moving forward. And the reason why I say that is that one, as in a study from Alina Allen in published online in Hepatology, this is something that we'll be dealing with more and more as every year goes by, the prevalence of NAFLD increases and the incidence of NAFLD in our clinic rises steadily. And two, that not all components of the fatty liver disease spectrum will require intense evaluation and management by hepatologists. As we all know, it's obviously a spectrum, ranging from simple steatosis to inflammatory disease and NASH, and within that, NASH cirrhosis and cryptogenic cirrhosis. And this is important to discuss briefly because liver fibrosis, but not the other histologic features, is associated with long-term outcomes for patients. And this is something which is reproduced no matter which sample of patients you look at. And so I have in this slide and the next some of the clearest examples whereby it is only patients with advanced fibrosis, that's F3, F4 fibrosis, who are developing liver-related morbidity and mortality or ever presenting for liver transplantation. It's not an absolute, obviously, but most of the patients who develop complications are those who have, at baseline, at the time of their evaluation, an advanced burden of fibrosis. This is something that we see in the US. It is something that they've seen in Europe. Again, any study that looks at it will reproduce those findings. So if fibrosis stage is the strongest predictor, then what we need is a tool that helps us do a couple of things. One, helps us risk stratify people for the presence of advanced fibrosis, and two, do so efficiently, because we can't see 50% of the diabetic population in liver clinic. And we have to come up with a tool that identifies people who benefit from consistent follow-up and intensified management of their underlying comorbidities and underlying disease process at the time of their original liver visit, so that we can say who can safely follow up with their primary care doctor or who will need advanced care. This is something which also brings up a point about the role and the benefit of that intensified management. Modeling studies from this point forward show that NAFLD will begin to present with a tidal wave of cirrhosis, decompensated cirrhosis, hepatocellular carcinoma, and it will be the leading indication for liver transplantation by, at most, 2030. The prevalence of advanced liver disease like decompensated cirrhosis is going to nearly triple over the next 15 years. And so what this means is not only do we need to find the people that can safely follow up with their primary care doctors, but we also need to actively seek out the people who will benefit from intensified lifestyle management today to prevent these adverse events tomorrow. So whenever I talk with primary care doctors, I always simplify things and say that you have many patients that have elevated liver enzymes, and you have many patients who have steatosis on their ultrasound. But it's not something that just because it's common, we can ignore. So the first commandment is to perform a risk assessment. But how? So the gold standard is liver biopsy, and it will always be there for us, but it's worth bringing up that there are a few limitations. One, there are complications, albeit rare, but they weigh heavily on the minds of patients when talking to them about the risks and benefits of a procedure when they're otherwise well. A liver biopsy also has sampling error. You can stage someone as advanced fibrosis or stage 1 fibrosis, depending which lobe of the liver you sample, because NASH and advanced fibrosis is, in fact, a heterogeneous condition. There's human error. You might have gotten a stage 4 liver biopsy, but it was simply missed by the interpreting pathologist, and it turns out that even in the studies where pathologists settled on the Medivir criteria, the interclass coefficient, that is the reliability between two raters about the burden of fibrosis, was far from 100%. And of course, there are significant costs with liver biopsy. It costs money to have someone come in for that day case procedure. It costs money to have an expert pathologist read it. But it also costs productivity, both for the patient who has to spend a whole day away from work and their chaperone who has to take them home, particularly when we're providing some mild sedation for patients at the time of liver biopsy. So for this reason, many different alternatives have emerged. And in this context, whether we like it or not, the world has changed. And one of the focuses of this particular webinar, as opposed to others that have dealt with the new guidelines as they relate to the incorporation of FibroScan into clinical practice, is that I want to take a deep dive into this new world. How do we interpret the findings of our non-invasive tools in the context of their test characteristics? And how do we apply them to patients when there's going to be uncertainty and variability in patient preferences? So next slide, please. So the the first thing that I wanted to go over was here, a little bit of. So in terms of the new world with non-invasive tools that are available to us, there are many different options that are available. In general, these vary between serologic tests that incorporate tools that are available in standard labs, and sometimes they'll require being sent away to reference laboratories. And then there's elastographic tests, such as the FibroScan, magnetic resonance elastography, which give us more of a sense of the viscoelastic properties of the liver. That is how stiff the liver is, and we know from paired biopsy studies that that stiffness correlates with advanced fibrosis. And I'm going to talk mainly about the free serologic tests, but even by limiting the world down to those, there are many different tests that are available to you, and we have to choose at least one of them to use in our clinical practice. And each of them has their trade-offs, each of them has their benefits, but for a given patient in front of us, a decision must be made. So how do we inform that decision is based on its test characteristics, but also the underlying biology that explains why each of these tests work and why they may fail a given patient. So many of us already know this, but it's worth reviewing, that the reason why we can have non-invasive tests are that there are a couple of things that are patently obvious to us based on years of research. One is that when the ratio of ALT to AST begins to narrow, and ultimately the AST begins to exceed the ALT, this often reflects the presence of advanced fibrosis. This was originally detected in groups of patients who were followed longitudinally who had hepatitis C but were not eligible for therapy. And that test in and of itself, the AST to ALT ratio, is not particularly sensitive or specific. But when you start adding other factors to it, such as the clotting proteins, which are further decreased in diseased livers, you can start to build a more sensitive test. But the most sensitive component of the blood with respect to the burden of liver disease is the platelet count. And for a variety of reasons, a diseased liver will result in a lower platelet count. Namely, with less liver reserve, there's less thrombopoietin and therefore platelet production. With portal hypertension, there's hypersplenism and sequestration of platelets. And we use these insights and bundle them into the most popular non-invasive tools, including but not limited to the Fibrosis 4 Index and the NAFLD Fibrosis Score. The Fibrosis 4 calculator is something which is easily Googleable and includes 4 factors. One is age. The longer you have a condition, the more likely it is to have caused advanced fibrosis. The AST to ALT ratio and the platelet count. And the specific cutoffs which are helpful to us vary by diseases. Now, there are low cutoffs for the Fibrosis 4. For example, 1.45 for hepatitis C, or 1.3 for patients with NAFLD. These have been conditioned within larger biopsy-proven cohorts. There are also high cutoffs that are indicative of advanced fibrosis, like 3.25 or 3.45, depending on which study you look at. This raises 2 issues. One is that there is a gray area between these cutoffs, and within that gray area, if your patient should land, another test would be indicated to advance their care. And 2, that we've seen this with Fibrosis 4, and we'll see it with all other tests heretofore, and that is that these tests have a higher negative predictive value than they do positive predictive value. Of course, the higher your FIB4 score, the more likely it is that you truly do have advanced fibrosis. But when we're using cutoffs that were determined from the area under the receiver operating characteristic curves within any given study, these might be optimal for a given cohort, but they do leave a lot of patients who have normal liver fibrosis burden behind, or they misclassify them as advanced fibrosis. So if the other test that's available for free that's widely validated within patients who have NAFLD is the NAFLD fibrosis score, which also includes the metabolic syndrome, BMI, and diabetes as something that can be predictive of advanced fibrosis. And this starts to key us into thinking about where we should be pointing our tools if we wish to screen the population, because in fact, things like diabetes and elevated BMI are associated with a higher burden of liver disease. When you're using these tests, keep in mind that if a 90-year-old patient comes into your clinic with potential NAFLD and you wish to use a non-invasive test, then the specificity of that test is going to decline substantially because, in fact, age is a part of the algorithm. So these tests were applied for a lot of all comers between the ages of 30 and 50. And you have to be careful into which population you're applying. And it might be that if, in fact, this would change your practice to determine the burden of advanced liver disease in a patient with NAFLD at the age of 90, this might not be the test for you. We do not have highly validated cutoffs for that population. So for that reason, there are a couple of other tests which give us more of a physiologic sense of what's going on with the liver. And since most of us are familiar with vibration-controlled transient elastography, commonly provided at the point of care by FibroScan, I won't belabor this point, but essentially for anyone whose liver you can access within the range of view, that is, a patient who doesn't have a severely thick chest wall precluding our view of the liver from a percutaneous probe, FibroScan is a perfect test. For FibroScan, for patients who are not candidates for FibroScan, namely those who had a failed test or who you know have a very thick chest wall, one of the more increasingly validated alternatives is magnetic resonance elastography. This is a test which will tell you about liver stiffness, and it's worth discussing this slide for a couple of reasons. One is that when you look at the liver stiffness in studies of MRE, it's going to be lower than you find for patients with FibroScan or vibration-controlled transient elastography. And that doesn't mean that people are being downstaged by MRE. It's just that the actual liver stiffness as assessed through the mechanisms of MRE is registering lower. So the cutoffs for advanced fibrosis, while they might be something like 9, depending on your disease with FibroScan, it could be as low as 3.64 for patients who are receiving an MRE. Now, there are a few tests that will look at these physiologic characteristics of the liver, and it's worth introducing 2 additional ones briefly. This is a slide that comes out of a paper that's in press, where I review the track record of each of these modalities in the context of NAFLD, because this is going to be the disease of our future, the cost per the test, a few words about confounders that I'm going to expand upon in later slides, and then a little bit about the quality criteria. So FibroScan has a pretty good track record in NAFLD. We know its ins and outs, and magnetic resonance elastography was essentially developed for this instance, for patients whose BMI was essentially too big for FibroScan. It's made for this purpose. And it's a newer test that's not available in many centers, and therefore its track record isn't as great, but it's certainly growing. Obviously, magnetic resonance elastography is going to be more costly because it involves an MRI and finding a center that has one. I also mentioned ARFE, or shear wave elastography. These are tests whereby a usual ultrasound can be retrofitted to tell you about liver stiffness. Now, these haven't been thoroughly validated in the setting of NAFLD, and the determination of their quality has been subject to much less rigorous assessment than has been performed for vibration-controlled transient elastography and MRE, but it probably will be in the future, so it's worth at least putting these on your radar. Things that can confound a FibroScan are those things that can confound any of the other elastographic tests. That is passive congestion from things such as congestive heart failure, possibly steatosis, liver inflammation, and potentially obesity itself. And when you review a FibroScan, you definitely want to be aware of its quality criteria that are provided to you automatically in the readout. First, you get a sense of the interquartile range over the median. And if it's greater than 25 or 30%, then this is not a test this is a test which may not be valid. You could consider repeating it or thinking about an alternative modality. And if the shot acquisition percentage is less than 60%, that is, the operator kept pulling the trigger but not getting enough shots, and after 100 shots they were only able to get 10, this may not be an adequate test. And of course, the FibroScan modality itself will tell you when an adequate window on the liver is not available. For MRE, or ARFE, or shear wave elastography, there is no such automated reminder that you're not in the region of interest. Rather, the region of interest within the liver is determined by the operator. And for that reason, we need to know a little bit more about the interoperator understanding of regions of interest before we know that these tests are perfectly generalizable from center to center, scanner to scanner, radiologist to radiologist. But of course, that's research that can be easily done. Another factor which plays into the validity of each of these tests is operator experience. Because FibroScan's been around longer, we know a little bit more about how many tests make a reliable operator. And in general, if you're doing more than 50 tests, you're likely to be a reliable operator. In the NASH CRN group, when they looked in a multi-center study at the proportion of tests that were unreliable based on those quality criteria, they dropped from about 5% to 1.6% once the operator has gone over 50. This is probably something that applies to the other tests. It's just not a study that's been done. And it is important to keep in mind, if you're going to begin using this clinically, that you have a consistent operator in your clinic, be it yourself or an assistant. Inflammation will interfere with liver stiffness, and this is something that we showed in an earlier study where we only looked at the people in the registration study for FibroScan's FDA approval who had F2 or less fibrosis. And yet, by many other centers' criteria, many patients were being registered as having advanced fibrosis. Because we're interested in understanding those patients who are at risk for a false positive, it is worth reviewing this study. Namely, patients who have an ALT greater than 100, those are patients who are at risk for a false positive, because inflammation contributes to the viscoelastic properties of the liver and acts just as fibrosis would in terms of the interpretation of liver stiffness. But it's notable that if you perform an elastographic study, be it FibroScan or MRE, in a patient with elevated liver enzymes, but you receive a low result, that result remains valid. It changes the positive predictive but not negative predictive value. Previously, we reviewed the potential sources of confounders, and this is something to keep in mind when you're selecting an appropriate test. One, obviously inflammation. Two, anything that increases liver stiffness is going to cause a false positive, and if you increase the blood flow into the liver, be it from passive congestion or from just eating a large meal, these are things that will increase your liver stiffness, and for that reason it makes sense to have as a protocol in your clinic that you have patients fast for 3 hours prior. Other things that contribute to liver stiffness are cholestasis. If you have an alkaline phosphatase that's very high in a patient with PBC, this will result in a higher liver stiffness. And for that reason, the cutoffs in patients with cholestatic liver disease are substantially higher than those with fatty liver disease or viral hepatitis. Alcohol will also increase liver stiffness. And now it's relatively routine, but if you are going to be using this probe on patients who have an average BMI greater than 30, you should have an XL probe available for your use. There are a couple of studies, the original one from Petta and his group in Italy has shown that one's liver fat burden as measured by histologic steatosis or controlled attenuation parameter may increase the rate of false positives. Now, this was present in a relatively small group of people, 14 or 15 people by tertiles of controlled attenuation parameter, and needs to be repeated in larger groups. But it is something to keep in mind that you may be assessing steatosis when you determine one's liver stiffness. And as we'll discuss, there's a role for further research that will further classify our cutoffs for advanced fibrosis based on the presence of heavy fat burden vis-a-vis controlled attenuation parameter, often provided at the same time as your liver stiffness measurement. I'm just going to leave this slide here for future reference. And in this slide, we review in a forthcoming paper the various cutoffs that have been provided for the determination of advanced fibrosis using M and XL probes, the areas under the receiving operator curve, and the fail or unreliable rate, largely with respect to the average BMI of the population. The failure rate can range from about 4% to a quarter, and that's something to keep in mind when you have patients who have markedly elevated BMI. I'm going to settle on a couple of cutoffs from these studies, ones that maximize negative predictive value. And I'm going to show how that can be used in clinical practice in just a moment. So the way that we use these cutoffs has to take into account the patients that we're using them on. And in a word, this is pretest probability. So this is the Bayes theorem. And I want to walk through it a little bit because I'm going to show how this plays out given our sense of the patient's burden. So every patient that comes into clinic has a prior probability of advanced fibrosis. If they're referred to a hepatology clinic, chances are they're more likely to have advanced fibrosis than not. If they're older, have severe diabetes, and you already know that their platelet count is low, your prior probability is high. And when your prior probability is high or low, this changes what kind of test you're looking for. You may be looking for a test that has a better positive predictive value if you already have a high prior probability. Or for the most part, because most of our patients don't have a very high prior probability, we're more interested in applying a negative likelihood ratio, or the probability of a person with advanced fibrosis testing positive or negative by divided by the probability of a person without advanced fibrosis, which is the positive predictive value, or divided by the probability of a person with advanced fibrosis, the negative likelihood ratio. When we can apply these things, we get a posterior probability. We can never really be certain, even with a liver biopsy, and how we counsel patients is dependent entirely on how we calculate that posterior probability in the presence of our patients. So let's see how this plays out. First, we should know that a good positive likelihood ratio is 10, and a good negative likelihood ratio is 0.1, whereas 1 for each of these has no effect on changing our clinical practice. So starting with a population where it's a coin flip, they're coming to see you in clinic, they could or could not have advanced fibrosis depending on what you know about the patient. So when that pretest probability is 50%, and then depending on their underlying disease, when we apply the various cutoffs for FIB4 or VCTE or MRE to that population, we can end up with a different prior probability. So beginning with 50%, a FIB4 can take us down to 11% for patients with hepatitis B, whereas a FibroScan can take us down to 14% with hepatitis B. Similarly, for non-alcoholic fatty liver disease, we can go down to 24% or 27% with the commonly available non-invasive tests. But a FibroScan, if you set the cutoff very low at 7.9, you can take your patient from 50% all the way down to 0. And rarely are you going to be able to move the needle much more than 85 or 95% with any of the non-invasive tests. Whereas a high cutoff of the NAFLD fibrosis score or a high cutoff for FibroScan will knock you from a 50 to an 80 or 90% posterior probability. The same is also true about magnetic resonance elastography. So after this first pass test, you can change that patient's post-test probability, and you can determine the relative value for that given patient, given their comorbidities, preferences, or the costs of future tests, whether it makes sense to simply treat them as if they have advanced fibrosis, and that is enroll them in semi-annual ultrasounds for screening for pacellular carcinoma, or to pursue additional diagnostic tests. Now imagine applying these tests to primary care, where a patient could present with a 10% prior probability. In this case, no matter which modality you use, you're going to end up with a low pretest probability when the test is negative. And you're not going to see much incremental benefit from sending all low probability patients for a FibroScan or magnetic resonance elastography. And it's in this case, the low pretest probability patient, that the serologic tests like the FIB4 really shine. By taking you from something like 10% to 6%, you're really solidifying what you had already thought based on your gestalt, your initial assessment of their pretest probability. But no test, MRE or FIB4, can really increase your certainty. So the positive predictive value, or the effect on post-test probability from a positive test in a low-risk patient is not enough to confirm that a patient has advanced fibrosis or not, and you really do run the risk of misclassifying people if you go based on just one test. So what I like to imagine is that those patients are the ones that have been referred. Ideally, I'd like to see someone where Gestalt or a FIB4 or NAFLD fibrosis score has assessed that person as being medium to high risk. So now we take those new pretest assessments based on the post-test, based on the cutoffs for each of these tests, like the FIB4, the NAFLD fibrosis score, and then we apply the more thorough test, the ones that are going to be a little more reliable, like the FibroScan or the magnetic resonance elastography. So just to review, on the left-hand side of our screen, we have FIB4s and NAFLD fibrosis scores. These are tests that primary care doctors, that anyone can do. They have referred you a patient, and because of that test, they have assigned that person a new pretest probability. They're coming to you because they've been risk assessed in the context of their primary care visit. Now you can see how a FibroScan or an MRE can take a person with a pretest probability of 68%, as in the case of hepatitis C or B, or 65%, as in the case of NAFLD, and move you towards close to 90% instead of much lower, as was the case when you were beginning with these tests for patients with 10% pretest probability. So there is no way to apply elastography to a low-risk group and achieve certainty. Elastography achieves something that at least approximates some certainty only when you've increased that pretest probability. And you can see here that when you use a high cutoff for FibroScan or MRE, you get roughly equivalent post-test probabilities. For NAFLD, MRE is going to does beat FibroScan at 88%, but you ask yourself clinically, how does this change your approach to the patient? And that's when you decide whether the difference between 95% and 88% matters. So you can imagine the scenario that you have a 35-year-old man or woman who may be staring at life with serial screening for ultrasounds and the risk of being characterized as cirrhosis for many, many years, or you have an older patient with comorbidities where the relative value of achieving incremental certainty through a test like MRE may be relatively limited. And so you choose the test based on how much certainty you need, and this is a relatively powerful heuristic to that end. So the way that we put this together is that you have taken a patient who you assess as medium to high risk, and you apply an elastographic test. But remember, we talked about how there's a gray area between these cutoffs. And so you are looking for concordance. If you have a concordant low-risk patient for cirrhosis, you can feel very certain. If you have concordant high risk for cirrhosis or advanced fibrosis, you can also feel certain. But if the tests are still indeterminate, this is where liver biopsy comes in as a tiebreaker, even though all tests remain uncertain. So here we'll just focus on the role of concordance, just to give you an example of how this plays out. When you take the positive likelihood ratio of a concordant test from a study as done by Petta in his population from Sicily, you can take a patient with 10% pretest probability or 50% pretest probability and move them to 100% very quickly if you have concordant FIB4 and FibroScan. Now, not everyone's going to have that, and you'll still have a lot of people that fall in that gray area. And that's where liver biopsy would play a good role. But if you are following this rule of seeking concordance, then you can provide at the point of care through a FIB4 and a FibroScan a very certain result for your patients. When you do this, you see how it plays out in terms of clinical care, and I'm just going to review very briefly how this impacts the costs of care that we provide. You could go straight to liver biopsy for the average patient presenting to you with NAFLD, or you could choose to go straight to FibroScan or combine FibroScan and a NAFLD fibrosis score, as we did in a cost-effectiveness study published a couple of years ago. And what you'll find is that a strategy that uses non-invasive tests, particularly one that uses the non-alcoholic fibrosis score and FibroScan, is going to improve patients' overall quality of life because they're avoiding some biopsies, they're being appropriately risk stratified and receiving appropriate care like screening modalities. And you're also, as we did in a follow-up study, going to be able to reduce the number of liver biopsies that are performed, but not completely. So we took this and we extended it further. Who should be performing these risk assessments? You could order a liver biopsy at any time. That's what we considered usual care. But if the risk assessment began in the PCP's office with a NAFLD fibrosis score, and they referred patients with indeterminate or high NAFLD fibrosis scores, that is the most cost-effective strategy. It is better for patients, improves their quality-adjusted life years, and reduces costs for the system. And if you look at the overall number of liver biopsies that we're performing, we're still going to biopsy people with indeterminate results. You don't have to, but in this model, that's what we simulated. And we're biopsying about 25% of all people. And if you went with the concordant strategy, you may achieve reduced costs, as we showed, but you're going to increase the number of liver biopsies for the benefit of improved correct classifications. Simply using a NAFLD fibrosis score is going to paint with a broad brush, and it's going to assign a lot of people as advanced fibrosis who don't have it. They're going to get a lot of ultrasounds for no particular benefit, whereas the certainty that comes from concordance in NAFLD fibrosis scores and FibroScans will take you down the road towards more liver biopsies for indeterminate results, but a better classification of the population overall. So I don't really want to take up your time for this, but rather leave this here for future reference. These tests can be applied in the non-invasive evaluation and management of patients with viral hepatitis as well. Obviously, we're using it for hepatitis C, but hepatitis B is going to be there for at least a long while, and we have to come up with a way of evaluating patients who don't prefer to have liver biopsies. And if you overlay AASLD guidelines onto a non-invasive strategy, as Dr. Afdal and I did in our textbook chapter on the topic in Zakim and Boyer, you can see how a FibroScan will play a role for patients who don't meet outright criteria for treatment, and how the same rules will still apply by seeking concordance between non-invasive fibrosis scores and FibroScan. And if you're looking for cutoffs that are conditioned on the underlying population of hepatitis B patients, I've made that available in a prior slide. In general, this is how we're approaching patients with NAFLD. They enter into our diagnostic pathway by not having a low FIB4 or NAFLD fibrosis score. And we're choosing whether to go to BMI go to MRE based on their BMI. If you want to be very conservative and FibroScan is not available for you in the clinic, patients with a BMI greater than 40 and potentially 35 could go straight to MRE. But beyond that, a FibroScan with an available XL probe is going to help you classify the remainder of patients. And for those failed or unreliable results, we then go to MRE. And if you still don't get reliable or highly discordant results, liver biopsy is there for us. I have a little post-it here in this picture of the cutoffs with the highest negative predictive value available. And at the bottom, after you've classified a patient as having advanced fibrosis, you can further classify patients on the basis of how stiff their liver is. And I think we all recognize that there's a spectrum here. You know, when we're using a cutoff of 6.9 or 7.9 to tell us the highest negative predictive value, once you've discovered that a patient has cirrhosis or advanced fibrosis, they could have levels as low as 9.9, 10.5, 12.5, depending on their underlying disease. And yes, they may have advanced fibrosis, but there's a wealth of studies that show that of the people who have been classified as cirrhotic, it is those with markedly elevated FIB4s, or as in the case of this paper from Spain, liver stiffness from FibroScan, who are at risk for adverse events. And it turns out that if you go based on liver stiffness and platelet count, and this is something which has been essentially codified in our society guidelines, both the AGA and the AASLD, if you have a platelet count greater than 150 and a liver stiffness less than 20, then the odds that there is clinically significant portal hypertension present in that patient is 5% or less. And so in practice, many of us are actually foregoing endoscopic screening for varices on the presence of a normal platelet count and a relatively preserved liver stiffness. So this slide is here mainly as a reminder that there is some prognostic information in addition to the presence of advanced fibrosis that's available in liver stiffness, and it helps us further delineate how these tests can make care more cost effective. And that's something that hasn't been incorporated into previous cost effectiveness models. So to summarize, we're moving from staging to a risk profile. Does your patient have a risk of advanced fibrosis or not? And if they have advanced fibrosis, are they at risk for clinically significant portal hypertensive events? I often receive emails and phone calls to hear about the cutoffs for F1, F2, F3 fibrosis, and that is something that you'll find in review articles and even guidelines. But in general, the gray areas are too great, and you have to start using the cutoffs that will give you the most certainty in terms of negative predictive value, and later through concordance, positive predictive value. Accurate risk assessment is a team activity. There is no one perfect test. And in order to serve our patients best, we should be combining tests. And that we need a strategy to identify high-risk patients. It is not enough to use tests in an ad hoc way, but rather we should be consistent with how we approach our patients, and future studies should look at how we approach the populations that we care for. We shouldn't wait until patients develop decompensated cirrhosis to present to our clinic, but rather we should be looking for underlying risk factors, be it viral hepatitis or advanced metabolic syndrome, and identifying patients who are high risk who may or may not benefit from our services. In terms of lingering questions for research, and this is my slide to conclude on, one of the things that we didn't get into but is worth thinking about as you reflect on the slide where there are the failure rates for each of these modalities is that when you criticize a study about elastography, you have to evaluate it in terms of its intention to diagnose. All of our clinical pathways that we presented here take care of all patients. If you have a failed FibroScan or MRE, you have to have an alternative available. And oftentimes the test characteristics ignore this fact, excluding patients who had an unreliable test. And so that's why the cutoffs in your own clinical practice may vary. We need to look at quality criteria for MRE and to be honest, also ARFE and shear wave elastography. And once we have a better sense of that, we can have a better sense of how one lab's MRE applies to the next, and one group's cutoffs apply to your particular patients. The strategy that I laid out where we go from FibroScan to MRE has not been assessed in terms of its cost effectiveness, and this is something where the study is underway. We're looking for confounder adjusted cutoffs. We know that ALT and that alkaline phosphatase do impact the cutoff that we use for common liver diseases. But how does steatosis or controlled attenuation parameter play into our interpretation of those fibrosis cutoffs? And now that we're treating everybody with hepatitis C, including those who have cirrhosis and decompensated cirrhosis, or we're referring all of our patients with NAFLD for advanced lifestyle modifications, what is a clinically meaningful change? When can I stop screening patients for hepatocellular carcinoma once I have stratified them as having cirrhosis? And the short answer at this time is that we don't know. But luckily, studies are underway. And I'm hopeful that within the next 5 years, we'll be able to answer this question in a meaningful and practice-changing way. So with that, I'll close, and I'm excited to hear any questions you might have.
Thank you, Dr. Tapper, for that very informative presentation. I particularly enjoyed and benefited from your statistical perspectives on test probability. Sunil Hasmain, my colleague, has been monitoring the questions in the background, and he will now present those questions to Dr. Tapper. We have approximately 15 minutes, so Sunil, or I'm sorry, 10 minutes. Sunil, if you would read the first question, please.
Sure. So thank you for the presentation. I just wanted to mention to everybody, if I don't get to your question, I sincerely apologize. Please email those questions to Jerry, and we can certainly answer them as we can. So the first question was with regards to the non-invasive scores. So we discussed FIB-4 and NFS in particular in this presentation. Jerry, you may want them, or somebody may want to mute their line because there's an echo. Okay. The question is about, well, a lot of these scores are comprised of, as you mentioned, AST, ALT, platelets, and many of these patients, at least what we've heard in the field, is that some of these patients don't really present with any of these factors as they come into the clinic. So is there ever a clinical situation where a patient comes in with a low FIB-4 or low NFS, yet you still have a suspicion of advanced liver disease and you still continue to work them up? Is there ever a situation like that?
So this is a key question, and when I present this data, it's mainly relating to how these tests will apply to whole populations. And when you do apply them to whole populations, They work really well. They are proven to be cost effective. But the reality is, for a given patient in front of you, you have to use your clinical judgment. And there is no algorithm that can replace that. And of course, like you, I've seen many patients on a weekly basis who present with relatively normal liver enzymes. And so I'll say two things. One, this is a perfect case for a FibroScan because we are willing to work out how to manage these indeterminate cases. If you're indeterminate on a FIB4 and positive on FibroScan or magnetic resonance elastography, shear wave elastography, this is a place where you go with your gut and one of the tests, or you use a liver biopsy to break the tie. And two, I often look at the absolute value of the ALT. And I've been surprised by how many people come to me with so-called normal ALTs because the computer says that it's normal when in fact it's 59. And I think at this point as a society, we can agree that a normal ALT for a woman is 19 and 29 for a man. And even within the range of normal, there are patients hiding advanced liver disease. So you may end up with an indeterminate FIB4 score when you have a low ALT or AST, and we don't want to leave those patients behind. So if you are worried about advanced liver disease, it's perfectly okay to go to the next test.
And sort of a related question is, the formulation and the way in which the two algorithms, the FIB4 and NFS, were, they're really created using kind of different patient populations. Both have obviously significant value. Is there in your clinical expertise, is there a rule of thumb where you may apply one versus the other, or do you look at both?
That's a very good question. I'm going to say two things. One is that virtually all of the studies which gave us these non-invasive tests were derived in patients with biopsy-proven non-alcoholic steatohepatitis. And you're not biopsying every patient. And most patients would be inclined to accept the liver biopsy if they were convinced that there was substantial benefit from it. And for that reason, these studies are enriched with higher risk populations. And it's worth understanding the pre-test probability of advanced fibrosis in the registration studies for NAFLD fibrosis score and FibroScan to understand the context in which they were originally applied. And it may not apply to your clinical context. The second question, the second part of this question is, do you use both, or is there a particular patient where you would use one? In general, you should not be using FIB4 to confirm NAFLD fibrosis score. And for those of you who use tests such as Fibrometer, FibroSure, HEPA score, the send-away test, which also assess the burden of fibrosis particles in the blood, essentially, they should not be used to confirm another serologic test. You should only confirm or refute a serologic test with an elastographic test. You're looking for incremental information from multiple different modalities. So in general, I'm using FIB4 because I personally find that the values have been more predictive in my personal practice, and that's something that I share with many colleagues. But there's not much data behind that.
Changing gears, so thank you for that. Changing gears, going to more of the physical biomarkers or the imaging modalities. There was a question whereby, and maybe you've experienced this in your practice, but there can be sometimes tension between livers, the liver practice and radiology over which test to use, which modality use. So there's a question that really came about a department in which this person who asked the question, their department, the radiology department, is very insistent on using shear wave elastography, and they believe it has good performance, as you've mentioned throughout this presentation. The data quite isn't there just yet; it's building. Do you have any guidance to give to this clinician in terms of how they should communicate with the radiology department to make the most of that test?
That's a tough question. It's actually one that we find ourselves in as well. And I'll say a couple of things. That historically, the original tension in this was between the hepatologists who wished to purchase a FibroScan and the pathologists who were worried that it would cut into business. In our practice, the number of liver biopsies hasn't changed, and that tension with pathologists has gone away as data has accrued. But now we're talking about a completely different fight for territory, as it were. And I think that if I were to be completely fair, ultimately you have to go with the modality that everyone in your shop is most comfortable with, and that you have to be using one or the other to be able to compare and assess across your population. There are a few problems with routinely applying shear wave elastography or ARFE to all comers simply because it can be added to an ultrasound. One is that it's not assessed at the point of care. And if we're going to make clinical changes in practice for patients who have driven a long way to see us, it makes sense to give that information in clinic. Two, we have to know about the quality criteria to know what we're talking about. And I think that even though I see the rapid spread of technology like shear wave elastography, because it can be easily added onto ultrasounds and potentially ultimately billed for, it's incumbent upon proponents of these tests to identify how they will perform quality checks on their assessments. And I would love to see papers about the inter-rater reliability of shear wave elastography between centers and operators. So at the end of the day, it comes down to a business plan. How to execute your practice in a way that helps everybody get along between your department, your hospital, and the other departments in radiology depends on whether that service is helping you at the point of care for the patients you take care of, and two, whether the values are in fact valid. So I think it's definitely worth a discussion to talk about where we stand now and how we should be doing things that are actively proven for patients, and there should be a plan to monitor how valid alternative elastographic tests may be for given patients. But my heart does go out to you on that one, because it's not clear how to navigate when you have a department that you have no control over making rational business decisions.
So thank you, Sunil, for posing those questions. Our time has been consumed. And thank you again, Dr.
Unmuted.
for your fine guidance on these important issues. Tracy, back to you to make final close comments.
And thank you. This concludes the question and answer portion of the webinar. And on behalf of the Chronic Liver Disease Foundation, I'd like to thank Dr. Tapper for his hepatology diagnostics presentation. This webinar has been recorded, and a copy will be available on both the CLDF and the EchoSense websites. All participants will receive a link to the webinar recording within 24 hours. Thank you and goodbye.